Thank you. Today I'll talk about the public health impact of temporomandibular disorder, or TMD. I'll address these 5 topics using results from epidemiologic studies of adults in the US population. And when I say TMD, I'm referring to that subtype of the condition where pain is the primary symptom. Epidemiologists need a case definition, and the DC-TMD provides a rigorous and evidence-based framework to classify the condition. It requires both patient history of pain and examiner verification that the pain is originating in the masticatory muscles or joints. Now, it turns out that this first self-report question works pretty well for population screening. In one study of women in New York, to investigate the question, the number of false positives and false negatives just about cancelled one another out, which meant that questionnaire-based prevalence was fairly similar to examiner-based prevalence of the condition. And that's good news for large population-based interview surveys such as the National Health Interview Survey that nowadays samples about 100,000 Americans every year. In 1989, it introduced this question about TMD symptoms, and in 4 years that I'm showing here, the percentage of people responding affirmatively was around 5%. To pick out 2009, prevalence was about twice as high in females as males. Across age groups, there was an inverted U relationship. With prevalence, the largest racial group difference was seen in Native Americans and people reporting multiple races, although there was seemingly very little difference according to between Hispanics and non-Hispanics. There was a conspicuous inverse income relationship, with prevalence elevated about 2-fold in people living in poverty compared to people living with incomes of 4 times or more the poverty level. This inverted U relationship with age is interesting because it's pretty much confined to women, and one theory is that the decline in older age is related to changes in female sex hormones. However, a single cross-sectional study can give misleading impressions about ageing effects. Now, when there are multiple cross-sectional surveys, it's better to use birth cohort analysis where prevalence is tracked in generations across successive surveys. And when that is done with the NHIS data, there is a clear decline in prevalence after about the age of 50. But note that the reductions extend well after that age, so I'm still not sure that changes in female sex hormones explain it. TMD has also been reported in the Hispanic Community Health Study, which was designed to capture diversity of America's Hispanic heritage. The study asked 2 screening questions, and these authors classified cases as people who reported both face pain and jaw pain. Overall prevalence was about 5%. Again, prevalence varied by gender, age and income. And this lower right panel shows marked variation among Hispanic heritage groups, about 2-fold variation from 3.9% in South Americans to 7% in Puerto Ricans. Studying TMD incidence requires a more time-consuming longitudinal study design, which is what we did in the OPERA prospective cohort study. It began with more than 3,000 people aged 18 to 44 years who had no history of TMD. After a baseline examination to verify their absence of TMD, we followed people with quarterly questionnaires for an average of nearly 3 years. And during that time, they completed quarterly health questionnaires. People responding positively to face pain symptoms were re-examined, and in this way we identified 260 incident cases of first onset TMD, which is an average rate of about 3.5% of people per annum. Incidence was greater in the older age group, but did not differ significantly by gender. However, there was a 3-fold difference in incidence between African Americans and Asians. We also re-examined these incident cases 6 months after TMD first developed and found that 49% still had persistent TMD. Persistence was more likely in the younger age groups, in females and in whites. I'll skip this. Now, when considering the public health impact of TMD, I like to step back and think about pain experienced by people who have subclinical levels of the condition. So during this follow-up in the OPERA prospective cohort study, 1/3 of people reported episodes of TMD pain in 5 days or more per month, which is a rate of 19% of people per annum. That rate doubled after the first episode, and for about 1/4 of people, pain intensity was intense during these episodes. Yet the vast majority of these episodes fell short of the threshold needed for DC-TMD classification of pain. But at a public health level, this is a different sort of pyramid, Dan. This constitutes an iceberg of symptoms submerged below the surface of what would usually come to the attention of the healthcare system. Turning to people with TMD, the term high-impact pain was coined recently to describe chronic pain that limits life or work activities. Von Korff used the same concept 27 years ago when he created the Graded Chronic Pain Scale. And when applied to TMD, the GCPS is used to define high-impact pain using both of these criteria. First, a score of at least 50 on a pain intensity scale, ranging from 0 for no pain to 100 for the worst imaginable pain. But second, also a score of at least 30 on a pain interference scale, ranging from 0 for no interference to 100 for people who are unable to carry on any activities due to pain. So we used this GCPS questionnaire in another OPERA study that enrolled people with chronic TMD. Overall, 1/3 of them had high-impact TMD pain, and prevalence increased with age, although it did not vary by gender. However, prevalence of high-impact pain in African Americans was twice that of whites. In our current OPERA study, we investigated 4 comorbid conditions in detail: irritable bowel syndrome, low back pain, a headache, and fibromyalgia. In people with TMD, only 1/4 had TMD alone, as shown by this cutout slice in this pie chart. 1/3 had one other condition, 1/4 had 2, 12% had 3, and 5% had all 4 of these other conditions. These are the same TMD subjects who also recorded pain on a body mannequin, where high proportions reported pain in the neck and shoulders extending to the upper back, as shown in these bright red shadings. The hips, knees, feet and wrists were endorsed by around 20%. So this is another type of iceberg. This is a symptom iceberg in which people with TMD experiencing pain elsewhere in their body. Risk factors for TMD have been investigated in more studies than I have time to review. I'm just going to cherry pick sound bites from a review we published from the OPERA study. And yes, somatic symptoms, but let me emphasize symptoms, not somatization, not somatic reactivity. Somatic symptoms were by far the strongest predictor of TMD incidence. Comorbid conditions were likewise predictive, and they included non-painful conditions, such as insomnia, allergy, and jaw symptoms like tiredness and stiffness. Among the clinical variables, oral parafunction and TMJ derangements were strong predictors, although interestingly it was the patient report that did a better job statistically of predicting incidence than the examiner findings. Sleep is both a cause and a consequence of pain, and as I'll show in the next slide, we found that impaired sleep contributed to subsequent risk of developing TMD. In contrast, pressure pain thresholds seem to vary more as a consequence of TMD than as a cause. Psychological stress was also an important predictor, and its effect on TMD was modified by people's genotype, which I'll show in a moment. Other genetic associations were probably better understood in terms of their combined effect on biologic pathways rather than effect of single SNPs. And finally, and Bill's covered this elegantly, when considering the hundreds of variables simultaneously, we used sophisticated machine learning methods to best distinguish the strongest risk factors for TMD. Now here's one example with sleep. Longitudinal studies are essential to sort out the cause and effect, and these red data points show worsening sleep quality prior to onset of TMD in the OPERA prospective cohort study. In contrast, the hollow black dots show no real change in sleep quality of people who remain TMD free. This slide shows that gene by environment interaction. In the overall cohort, stress, psychological stress during follow-up, increased the rate of TMD by a factor of about 1.8. but that was a 2.3-fold factor in people whose genotype created low activity of the COMT enzyme. Now, that enzyme catabolizes catecholamines, which are important to stress response. So this is a very plausible gene by environment interaction. These are new findings from Sonia Sharma's dissertation work showing that injury increases incidence of TMD by a factor of about 4 in the OPERA study. Furthermore, she's found the effect was amplified in people who are sensitive to experimental heat pain. Now, this is an interesting phenotype by phenotype interaction, not least at all because heat pain itself was not a useful predictor of TMD. Healthcare for TMD is a more difficult topic for me simply because I don't have as much data at hand and I'm more rudimentary. In OPERA, we used a 30-item checklist to capture professional services reported by people who developed first onset TMD. 57% reported one or more treatments over about a 6-month period. And remember, these are people who've developed first onset TMD. The percentage was greater for females, it was less among African Americans and greater among people whose TMD was persistent. The treatments themselves were dominated by medications and other conservative care, including massage and mouth appliances. But we know it's difficult to accurately report treatments in this sort of study, as suggested by the 18% reporting antibiotics, which hopefully is not something prescribed for TMD. A much more rigorous approach is used in the Medical Expenditures Panel Survey, or MEPS, which supplements patient-reported information with records from healthcare providers and insurance carriers. MEPS uses a large population-based sample of people who completed the National Health Interview Survey, which therefore provides a rich source of information about people's health status and socioeconomics. Now, this recent study from MEPS reported trends in non-cancer pain, of which TMD was just one. The top panel shows increasing prevalence of pain over a 18-year period. And the lower panel shows an increase in opioid treatments coupled with a reduction in ambulatory office visits during that time. And this is for pain overall. Now, in principle, MEPS should be a goldmine for evidence about TMD healthcare, but there are methodological barriers. The problem is that treatments for TMD in MEPS are recorded using the 4-digit ICD-9 code, whereas the publicly accessible MEPS data set collapses that to 3 digits. Now, the 4-digit codes can be analysed, but it requires special access through the National Centre for Health Statistics. The level of access is also needed to link MEPS data to NHIS data. Now, these are not insurmountable barriers. I've done it myself for studies of other conditions, but it's time-consuming and takes resources. It's taken a couple of years in the 2 times I've done it. So if I can summarise, prevalence of TMD in the US population is around 5% and has been consistent for 3 decades. There are marked inequalities according to demographic characteristics and income. In my mind, a big knowledge gap is the reasons underlying those demographic and even economic gradients. Incidence of TMD is around 3%, but that is a symptom iceberg of pain in the community at large. About 50% of people with first onset TMD develop persistent symptoms. And meanwhile, 1/3 of people with chronic TMD have high impact pain. There are multiple risk factors for TMD that cluster and that often interact. Somatic symptoms. Hear me again, somatic symptoms. Psychological distress, poor sleep, injury, pain sensitivity, genetics. I still think, and this is maybe just me, that we have a big knowledge gap in how the nature of those interactions work out. I think they're going to be critical for anything approaching personalised care. And turning to healthcare, 70% of people with persistent TMD sought professional care in a 6-month period. They reported a variety of treatments dominated by conservative care and self-management. I think, though, there's a big knowledge gap in healthcare for TMD. I think that's potentially solvable in the relatively short term by properly capitalising on the rich data source that we have in MEPS. I've included references for my presentation, and I thank you for your attention.
Thank you, Gary.